Moving on to the liver, I really want you to get a cup of coffee and really concentrate on this topic. It's very important for us. So first I want to talk about the surface anatomy of the liver. Okay, guys? That's the first thing. It's one of the most important topics, surface, projection or anatomy of liver. So it's very useful, especially in the context of the exam. They usually they ask you about it in the context of penetrating injury to the abdomen and lower chest. At which particular point or location would you say liver injury can be there? So, first let's talk about the upper border of the liver, okay? Of course, those are the two mid-clavicular lines that passes midway between the acromioclavicular and sternoclavicular joints. That is the middle section of the clavicle. So we're going to run them down the body. These two mid-clavicular lines, we'll run them down the body. And of course, when you just looking closer, I will highlight the superior border of the liver. So this is superior border of liver. All right. On the right side, of course, that's sternum, right? This is fourth rib and fourth costal cartilage, and that's fifth rib and fifth costal cartilage. On the right side, the superior border of the liver reaches as high as the right fifth costal cartilage and rib at the level of the right mid-clavicular line. Right, so this is on the right side, it is what? Fifth rib at right mid-clavicular line. But then the liver begins to slope downwards, such as that the left lobe of the liver is largely contained level with a lower level. So that's fifth rib, fifth left rib, and that's fifth left intercostal space, such as that at the left mid-clavicular line, the upper border left lobe of liver is located at fifth left intercostal space, fifth left intercostal space. So this is about the upper border of the liver, the upper border of the liver. So on the right side, it's level with the fifth rib at right mid-clavicular line, and on the left side, it's level with the fifth intercostal space, left fifth intercostal space at mid-clavicular line. Okay? So it means left side of liver is lower than right side of the liver. You get me? Okay. What about the lower border of the liver? Now look at the mid-axillary line. The lower border of the liver is opposite the 10th costal cartilage. 10th is at level with 10th costal cartilage. 10th costal cartilage. And then that's one point. We'll create one point here at the 10th costal cartilage. The other point is basically the tip of the left lobe of the liver, which is at the roughly, it's just slightly past the left mid-clavicular line. Slightly past the that is left mid-clavicular line. We'll just connect two dots. We'll connect these two dots together, and it will give us roughly the inferior margin of the liver. Remember that the inferior margin of the liver moves down and up with respiration, but in quiet respiration, these are the reasonable surface projections of the liver. So it means liver occupies the right hypochondrial region, the epigastric region, which is anterior to the stomach. It's in front of stomach and that is abdominal part of the esophagus. And small portion of it extend to the left hypochondrium as well, which is just the tip here. Okay? small portion of it extend to left hypochondrium. So that's surface anatomy of liver, all right? Okay. Remember that suppose if there's someone have a penetrating injury in the epigastric region just below the xiphisternum, of course, after the abdominal wall, the injury will be, what will be injured is the liver, right? Because stomach is protected by it, right? Okay. So that's surface projections of liver. There are anatomical variations that can be there, or situations in which the liver can be at a lower level, especially when we talk about the inferior border. One situation is that some people have an extension from the right lobe of the liver. It extends down, tongue-like, extension, and it's normal. It's normal anatomical variant, but you will find the liver extending way down below the costal margin, below the inferior border, that is naturally. This accessory extension of the liver is referred to as renal lobe, okay? It's called renal lobe. That's one situation where the liver may be lower. Another situation is that this colon, the transverse colon, may be superimposed between the liver and the diaphragm, right? And that pushes liver down. So this situation is called Chilaiditi syndrome or Chilaiditi sign. These are anatomical variations, but sometimes there are disease, like if the lung is hyperinflated in COPD, it will push liver down. If there's subphrenic abscess, it will push liver down. You get me? Okay. So that's about surface anatomy of the liver. Now I want to talk about the surfaces of the liver. Liver basically has two surfaces. Okay, it has two surfaces. I can draw a diagram here for you guys. And in this diagram, I will be showing in a sagittal section. Okay, so that will be the thoracic rib cage. Okay. Suppose that's T12, okay? And then we've got the diaphragm. Of course, here will be the sternum and xiphisternum. And that's like the dome of the diaphragm, right? Extending from the xiphisternum to T12. Okay. Liver is situated in such a way that it's like that. I will be doing it out of proportionally inferior so that you can see it better. So it has a surface which is oriented in the anterior, superior, and posterior planes. And then it has another surface which is oriented in the inferior plane. So that's one surface oriented in anterior, superior, and posterior planes, and another one oriented directly inferior. Okay? This surface is referred to as diaphragmatic surface. That's called diaphragmatic surface. This domed shaped surface is called diaphragmatic surface, right? Anterior, superior, and posterior planes. And this surface is called visceral surface because it's related to a lot of viscera. Okay? Now there's a very important point about the diaphragmatic surface. When we draw the, let me show you, again, that's diaphragm. Okay? When we draw the peritoneum, first I will draw the abdominal wall. I'll give it this color. That's abdominal wall. And this is the parietal peritoneum lining the inner part of the abdominal wall. Now, parietal peritoneum will also continue onto the diaphragm. And then it will leave the diaphragm. It's going to leave the diaphragm and then attach to the liver at various points forming hepatic ligaments, okay? And then it covers most of the liver and then reflects back into the back wall of the body. Now the thing is that there's an area of the liver which is related to the diaphragm, which is not covered by peritoneum. I'll explain it later, okay? We call this the bare area of the liver. But what I want you to know is that there is a peritoneal pocket or recess, right? Which is between the liver and the diaphragm, right? These are called subphrenic recess. This space is called subphrenic recess. Now, subphrenic recess have divisions because there's another fold of peritoneum which connect the anterior surface of the liver to the anterior abdominal wall, the rectus sheath, which is this one. So if you look at this dissection, we see what? We see that this is the diaphragm. Okay, let's orient ourselves. That's diaphragm, right? Those above is chest. This is the lung, right lung, okay? And we see that's liver, of course. This is our beloved liver, here, right? This is the right lobe. This is the left lobe. Now, there's a fold of peritoneum, which is this one. This fold of peritoneum is called falciform ligament. I will explain in detail, but it's called falciform ligament. It is just a fold of peritoneum that connects the anterior surface of the liver to the anterior abdominal wall. Now, this falciform ligament forms a division, a partition in the subphrenic space. So subphrenic space is over here, right? That's diaphragm. This is liver. And over here is the subphrenic space. I will highlight it to you. That's subphrenic space. Now, the falciform ligament, you can put your finger here, you can stick a finger. The subphrenic space is divided into right and left by the falciform ligament. So that's left subphrenic space, that's right subphrenic space. Is that right? Now, right subphrenic space is further divided. It's further divided into anterior and posterior portions, right? It's continuous with each other, but it's divided into anterior and posterior portions as well. Now, why these subphrenic spaces are important? They are a site of collection. They are a site of collection, especially post-operative collections. That is, after surgery, some pus or collection can be here and form a subphrenic abscess. So what are the borders of all of these spaces? First, let's begin with suppose this section through the anterior, that is surface of the liver, okay? That's a section in the anterior surface of the liver. Let me clear things up so that we can do it better. Okay, so that's our sternum. This is our diaphragm. This is our liver. Suppose that's a section that is going through the right lobe of the liver. That is to the right of the falciform ligament, right? So we're going to draw our liver here. That's the diaphragmatic surface, and this is the visceral surface, right? And we said that peritoneum will move like that and then reflect and attach to the liver, right? Okay, most of the liver. And that's like bare area of the liver, bare area of the liver. So this is the right subphrenic space, right subphrenic space, okay? As I told you, it's divided into anterior and posterior portions. So there is right anterior and right posterior subphrenic space. The right anterior subphrenic space, which is highlighted over here, is bordered by what? So superiorly, it is bordered by diaphragm, right? And inferiorly, it's bordered by the anterior surface of the liver, by the anterior surface of the liver. medially, if you go medial like this, medial, you will encounter the falciform ligament. And if you go laterally, it will be continuous with the peritoneum covering the lateral abdominal wall. This is the peritoneum covering the lateral abdominal wall. So right subphrenic space will be bordered on the lateral side by the parietal peritoneum, which is covering the right abdominal wall. And posteriorly, it just communicates with the posterior subphrenic space. It's continuous with it. Right? Right posterior subphrenic space. So again, what are the borders of right anterior? Above we have diaphragm, below we have anterior surface of right lobe of liver. Medially we have falciform ligament, laterally we have parietal peritoneum covering right abdominal wall, and posteriorly it communicates with the right posterior subphrenic space. The right posterior subphrenic space, which is this, right? It's very deep. What are the borders of that? Again, superiorly you still have your diaphragm. You still have your diaphragm superiorly. Inferiorly you have the upper aspect of right lobe of liver, right? And somewhat also it may extend to initial posterior aspect. But generally, the upper dome of the right lobe of the liver, that's below. Anteriorly, it's continuous with the anterior space. Posteriorly, there's a ligament here. Look guys, when the peritoneum was on the undersurface of the diaphragm over here, it will reflect and attach to the liver at this point. This point of attachment at the right side, we call it the coronary ligament of the liver. The anterior coronary ligament, anterior layer of coronary ligament. I will tell you all the ligaments later. So posteriorly is what? Coronary ligament of the liver, and the bare area of the liver is over here. So bare area of liver and coronary ligament. That's posterior. Now, to understand better the medial border, I'm going to take you guys to a 3D model. So in this 3D model, as you can see, that's falciform ligament highlighted over here, right? That's anterior aspect of liver. When we move to superior aspect, as you can see, the fold of peritoneum, right? That's the coronary ligament that I'm telling you about. There's an anterior layer, that's coronary ligament highlighted here, coronary ligament. There's an anterior layer, which is this. And when you go to the back of the liver, you will find another layer, right? There's another layer. Let's remove this. This is thoracic aorta and abdominal aorta. We'll remove that. That's IVC behind the liver. So let me show you again. Okay. So this is the other layer that I'm telling you about from the back. To look better, we need to go a little bit down. Yes. And it moves along this line. This is the posterior layer of coronary ligament, and in between them is the bare area of the liver. I'm doing it quickly, so I want to tell you something. Now, this is the right subphrenic space, isn't it? All of that is right subphrenic space. So we're talking about the right posterior subphrenic space, right? I told you above is diaphragm and below is superior surface of liver, and anteriorly is continuous with the right subphrenic space, and posteriorly is the coronary ligament, as you can see. Okay, let's remove that. As you can see, this is the coronary ligament that I was telling you about. That's posterior. Okay? Medial is this is considered continuation of the coronary ligament here that merges with the falciform ligament. Okay? So very posteriorly, it is actually the right layer of the coronary ligament that continues, eventually it becomes continuous with falciform ligament. But its initial part, this part, is called right layer of coronary ligament. That's medial. Lateral is actually part of the diaphragm. Laterally is part of the diaphragm. If we can move to the 3D model again. Okay, so diaphragm should be immediately here. So lateral border, you will hit diaphragm. Again, this is the most difficult part, the right posterior subphrenic space. Above, you got diaphragm. Below, you got upper dome of liver. Anterior is continuous with the anterior subphrenic. Posterior coronary ligament and bare area. And medially, the right layer of coronary ligament. And laterally, the dome of diaphragm as it descends. Now, the left subphrenic space is easy. It's described usually as a single space, right? Above is diaphragm. Okay, so this space is over here, right? This space is over here. That's the space. It's like I put probe in it. Left subphrenic space. Superiorly, you have, no fun in saying, diaphragm, right? Diaphragm is over here. So superiorly, you have diaphragm. That's above, superior border diaphragm. And inferior border is the left lobe of liver. Left lobe of liver. Medially is the falciform ligament, right? Simple. Medially is falciform. And laterally is actually what? Spleen. Okay, spleen is over here. So laterally, it's bounded by spleen. Anteriorly is just the anterior abdominal wall. In front, anterior abdominal wall. Posteriorly is what? If we see posteriorly is, look guys, when that's coronary ligament, as I told you, right? This is coronary ligament. That's what? Anterior layer of coronary ligament. And then I told you there is also a posterior layer, which is here. When you move to the back, there's a posterior layer. When the anterior and posterior layer come together, they form left triangular ligament. So this ligament is called what? Left triangular ligament. And they come together on the left side. So it means what? It means that the posterior border of this space is this ligament. This is the left subphrenic space, right? So posterior border is the left triangular ligament. So again, left subphrenic above diaphragm, below left lobe of liver, medial is falciform ligament here, posterior is the left triangular ligament here, and we have what else? Anterior is the anterior abdominal wall, which is here. That's anterior abdominal wall. So this is our beloved space. Okay, those are these subphrenic spaces. If we move back to this diagram, these subphrenic spaces are continuous with the abdominal cavity, right? It's a part of the greater sac, and it's continuous with this large recess, which is called Rutherford-Morrison pouch. It's basically a recess between liver and the right kidney and right suprarenal gland, because right kidney is supposed to be over here, right, behind the peritoneum. So this recess is just also in continuity with all of these spaces. Okay, so we talked about the surfaces and the spaces and the recesses that are there about the liver. Now, I just want to tell you about the visceral surface of the liver. This is an inferior view, visceral surface of liver. there are structures related. Of course, it's oriented in the inferior plane. It faces inferiorly, and it contains the porta hepatis, which is this gateway to the liver. Now, when we see the inferior surface of the liver, we see that the anatomical right and left lobes of the liver are divided by two fissures. Okay? This is the left lobe of the liver, is that right? And that's the right lobe of the liver. Now, in between them is this. This is anterior, right? That's posterior. Anteriorly, between them is a groove, a fissure. This fissure it's called fissure for ligamentum teres. Fissure for ligamentum teres. Actually, it's a remnant of the umbilical vein. In embryo, we talked about it in thorax anatomy in detail, but it's a fissure of ligamentum teres. It used to be umbilical vein. What's ligamentum teres? If you see in this diagram, 2 is ligamentum teres. Ligamentum teres is actually a ligament which is a fibrotic remnant of the umbilical vein. It connects liver to umbilicus. It passes superior and to the right from the umbilicus and attaches to the liver at this point, at the base of the falciform ligament, right? That's falciform ligament. At the base, there's the ligamentum teres, or simply called round ligament of the liver. It continues in this fissure. So it's called fissure, so it's like this. That's the ligament. It continues into this fissure. So we call this fissure for ligamentum teres. Then this fissure for ligamentum teres ends at the porta hepatis, and another fissure emerged from the posterior aspect of porta hepatis called fissure for ligamentum venosum. This is referred to as fissure for ligamentum venosum. Right, this fissure is the remnant of ductus venosus. It's the remnant of an embryonic structure called ductus venosus, which is this ductus venosus is supposed to divert blood coming in from the umbilical vein away from the liver. So it's a bypass channel. So that well oxygenated blood coming in from the placenta can bypass the liver and enter directly to the inferior vena cava and then taken to the heart, right? That's again in details in embryonic circulation as we've explained in the other lectures, okay? So it means if they ask you what divides right from left lobe, anatomical I mean, anteriorly falciform ligament, and from the visceral surface anteriorly is the fissure for ligamentum teres, and posteriorly the fissure for ligamentum venosum. So these are two distinct structures that we can see in the inferior surface. To the right, we have the gallbladder and the fossa of the gallbladder. And also we have a groove for the inferior vena cava. So inferior vena cava has a retrohepatic part that comes very important in clinical aspects and surgical aspects. And then we've got various depressions on the liver we don't have to know about. There's a depression made by the esophagus, there's a depression made by the stomach, by the duodenum, okay? Now, one may be wondering, where's the attachment of the lesser omentum that we talked about to the liver? Exactly where does it attach here, right? It attaches along these lines. It attaches along the fissure for the ligamentum teres, and then you've got this porta hepatis, that's like the free margin, and then from there it extends to the stomach. All right? Extends to that stomach and first part of the duodenum. Okay, so we talked about all of that, visceral surface of the liver. Now we're gonna just talk about the porta hepatis. The porta hepatis is, as I told you, is a part where it is not peritoneum. That's a section of the liver where it's not covered by peritoneum. And it contains the portal vein posteriorly, that's portal vein. It contains the hepatic artery proper, which is anterior and to the left. And it contains the right and left hepatic ducts and the common hepatic duct after it joins, and it is generally anterior and to the right. It's generally anterior and to the right. So in addition, it also contains porta hepatis lymph nodes and some lymphatics, other lymphatic vessels, and some nerves also, autonomic nerves passing inside of the liver. Okay, so now it's time to talk in detail about the ligaments of the liver. So ligaments of liver, as I told you, they are not like your ligaments that connect muscle to bone or bone to bone. It is actually muscle to bone is called tendon, sorry. Not connecting bone to bone, these tough ligaments. These are just folds of peritoneum. It's folds of peritoneum. So let's move from anterior and review what we've seen already, right? This is again a dissection, anterior surface of liver. We can see the ligament, the round ligament of the liver, or ligamentum teres, which is, as I told you, round ligament of liver, or otherwise called ligamentum teres. Ligamentum teres. This ligament, as I told you, it used to be umbilical vein. But then after birth, it just becomes, obliterated, fibrosed, and just disappears altogether, okay? So, let me tell you about it. That's umbilicus, that's abdominal wall, and this is your beloved liver. This is the falciform ligament of the liver, and it starts in the umbilicus and moves superior and to the right. Superior and to the right, like in this direction. Moves suprolateral and to the right from the umbilicus. Suprolateral. They love to ask about that, okay? Suprolateral. And then it ends where? It ends at the base of the falciform ligament, as I told you, and then it continues on the undersurface of the liver, grooving it in this way, right here, and it forms the fissure for the ligamentum teres. Okay, that's one ligament out of the way, two ligaments actually out of the way, the falciform ligament and ligamentum teres. Then we can move back to our 3D model and talk about the other ligaments. So that's anterior view. We just gonna zoom in a little bit to the liver, and we're gonna move up. That's falciform ligament again, right? Here, over here, that's falciform ligament. We're gonna move up, until we see in the superior surface the coronary ligament. So coronary ligament, it has two layers, as I've told you. An anterior, or also called upper layer, and a posterior, also called lower layer. So anterior layer is over here, right? It runs on the superior surface of right lobe of liver, and here it continues into, of course it's called right layer, and here's left layer, right, of the anterior right side and left side, and then it ends over here at this point. When we go to the posterior surface of the liver and then move down, and then we remove the structures here, and then just basically go to the inferior surface of the liver, we will see the other layer of the coronary ligament. Okay, so guys, that's called caudate lobe of liver. I'll tell you about it. This runs just to the right of it, okay? Runs just to the right, and then it deflects on the right side of the liver, right lobe. And then here at this point, as you can see, if we move like this, this is right lobe of liver. That's the anterior layer, and that's the posterior layer. Here they meet together and form another ligament. This is called right triangular ligament. Right triangular ligament. Then on the left side, move anterior, move up. Here the right anterior layer and posterior layer of coronary ligaments meet together and form the triangular left triangular ligament. At the end, it has like this tongue-like extension to the diaphragm called fibrous appendix of the liver, fibrous appendix. So those are the ligaments of the liver that I need you to know about. In between the anterior and posterior layers of coronary ligament, we have the bare area of the liver where no diaphragm is there. This area is actually have some clinical importance as well. It's one of those portosystemic shunts, right? You know portosystemic shunts? The ones that in portal hypertension open up and allow blood to bypass the liver because there's high resistance of blood flow in the liver and enter into the systemic circulation, isn't it? Like caput medusae, like the lower esophagus, etc. One of the other areas which not a lot of people know about is the bare area of the liver, right? So there are veins on the capsule of the liver that communicates with the portal vein. That's on the portal side. And on the systemic side, there are veins which are under the diaphragm, okay? So let's move to anterior view again, or let's see like that a little bit up. And then just draw the diaphragm over here, right? And there are veins running on the undersurface of the diaphragm here, which are called inferior phrenic veins, okay? And so there are veins on the capsule of the liver, right, that moves in the bare area and then connect with the inferior phrenic veins on the systemic side. So on system side, we have inferior phrenic vein, and on portal side, we have capsule veins, right, veins of the liver. Okay, good. Now I want to talk about lobes of liver, anatomical lobes of liver. Okay, so anatomical lobes of liver, of course, we have right and left lobes. Everybody knows about that, right? So we have right lobe and left lobe, divided anatomically by falciform ligament anteriorly, and on the visceral surface, it's divided by the fissure for the ligamentum teres anteriorly and posteriorly by the fissure for the ligamentum venosum. We already said that. Then we have two additional lobes. There's a lobe over here which is called quadrate lobe. This quadrate lobe, you have to know the borders of this lobe. So to the left, we have the fissure of ligamentum teres. That's the left border. The right border is the gallbladder, fossa for gallbladder. And posteriorly is the porta hepatis. Posteriorly is the porta hepatis. Anteriorly is the inferior border of liver. Okay? So this quadrate lobe, anatomically, it looks like it's on the right side. But functionally, it actually belongs to the left hemiliver. I will tell you all about that. There's actually functional liver and anatomical liver. Okay? So this is called quadrate lobe. So again, quadrate lobe is anterior. If you remember, it's related to duodenum. Remember from the earlier part, it's related to a part of the duodenum. So remember the borders. So on the left, we have fissure for ligamentum teres. On the right, we have fossa for gallbladder. Posteriorly, we have porta hepatis, and anteriorly is the free border of the liver, lower border. Quadrate lobe. And posteriorly, we have this lobe. This one is funny lobe. This one is called caudate lobe. Remember that was the superior border of a foramen of Winslow, remember? Caudate, here it is. That's caudate lobe. Caudate lobe is actually, here we are seeing it as that it is posterior, but it's actually posterior and superior. Because why? If we can draw a section, sagittal section in the liver to show you guys, okay, at the level of the caudate and quadrate lobes, okay? So that's caudate lobe, that's sagittal section at the level. sorry, that's quadrate lobe, quadrate lobe. Of course, that's anterior, that's posterior. So quadrate lobe, and that's your caudate lobe. So actually caudate lobe is posterior and superior. Quadrate lobe is anterior and inferior. They are not at the same level, right? Caudate lobe is above, quadrate lobe is below. So that's one thing. Caudate lobe is, now we know the location of it. On its left, there's the fissure for the ligamentum venosum. That's the left border. On its right is the groove for the inferior vena cava and inferior vena cava. That's inferior vena cava. And anteriorly, it is what? Porta hepatis. Porta hepatis. Now there's a very important thing in hepatobiliary surgery related with the caudate lobe. So now I'm going to tell you the clinical aspects of caudate lobe. First clinical aspect is that I'm going to move you guys to a dissection. That's the visceral surface of the liver. Let's get ourselves oriented, okay? That's left lobe, that's right lobe, that's gallbladder, that's quadrate lobe, that's the fissure for the ligamentum teres, and caudate lobe is here, right? That's caudate lobe. Okay, now, if you can see, caudate lobe has this, there's a bridge between the caudate lobe and between the right lobe of the liver. This bridge, okay? This bridge of liver tissue, we call it caudate process. We call it what? Caudate process. Caudate process. Now, caudate process moves and merged with what? With the right lobe of the liver. But between them, as it does so, there's a groove created. So the entrance of this bridge to the right lobe of the liver create a groove, or you can say a sulcus, okay? Very important for us, the sulcus. The sulcus is called Rovier's sulcus. The sulcus is called Rovier's sulcus, okay? Now, Rovier's sulcus is a horizontal sulcus. It's a horizontal sulcus, right? On the visceral surface of the liver, right? Located between caudate process and right lobe of liver. Is that right? In fact, it's actually located between two segments of liver, segment 5 and segment 6. Okay, the segmental anatomy of Rovier's sulcus is between 5 and 6. I will come to that, the segmental anatomy. Now, what is the importance of this sulcus? If you take a horizontal line at the level of the sulcus, right, behind this line, of course, to remind you, that's anterior, that's posterior. Behind that line, dangerous area of dissection during cholecystectomy. During cholecystectomy, when you dissect behind this line, or Rovier's sulcus, that's the area of the common bile duct and porta hepatis structures. So you may injure that. Whereas dissection in front of this line will be safe because that's gallbladder and cystic duct. So it's used as a landmark. It's present in 80% of people, so we're lucky that this sulcus is present in 80% of people. But laparoscopically, that's laparoscopic view. Now, what's happening? That's the grasper. The surgeon holds the fundus of gallbladder and move it up so that the liver is everted like that. So we are seeing here is the visceral surface of the liver after the liver has been retracted superiorly. So laparoscopically, we say that this is sulcus of Rovier's sulcus, right? And that's the line with it. So we say above line, below line. So above the line, that's safe dissection, because what you see is cystic duct and gallbladder, safe dissection. Below the line, that's bad. Below the line, you will have bile duct, which is this one, right? So you can injure bile duct below the line. So remember this, stay always above the line. Stay always above Rovier's sulcus. Okay, very important thing to do. Does it contain anything anatomically? Yes. This Rovier's sulcus, guys, it contains branch from the portal vein called the right portal vein, right? Because if we move to this cadaveric dissection, portal vein is gonna give the right portal branch that goes to the right side of the liver. This right portal branch passes in Rovier's sulcus before branching inside of the right liver. And it also contains the right hepatic artery. Of course, hepatic artery divides into right and left. The right hepatic artery also passes in Rovier's sulcus before moving to the right side of the liver. So it contains two things basically. It contains right portal vein and right hepatic artery. So it has contents, okay? Okay. You know what's the vertebral or the plane at which porta hepatis exists, guys? Just a note, side note. It's at the transpyloric plane. It's at L1. Just in case they ask you. Okay? Good. So we talked about anatomical lobes of the liver. Alright? But I want to talk about functional liver. You know, functionally, the liver is divided into two hemilivers. So that's the visceral surface of the liver. Okay, as we know, that's left lobe, that's right lobe, that's quadrate lobe, that's caudate lobe. Those are the lobes of the liver that we know about, right? Now, we will take an imaginary line. We'll take an imaginary line starting from the fossa of gallbladder and moving to the inferior vena cava at level with middle hepatic vein. We know that the liver is drained by three veins, right, left, and middle. Now, this line, which crosses from the fossa of gallbladder to the middle hepatic vein, we call it can't lie's line. We call this line what? I can't lie, can't lie. Actually, that's the name of a person, okay? Can't lie's line. But, well, of course, we know everybody lies. But anyway, can't lie's line. There are white lies and dark lies, or black lies. Depends on the purpose of the lie. There are good lies and bad lies. This is one of the good lies. Can't lie's line is a good lie. It's not a lie, it's a reality. But it divides liver into two sections. Right and left hemilivers. Right and left hemilivers. In total, we have 8 segments. Then they are broken down into functional segments. Each segment acts as an independent unit. Okay? So, if you see, segment 1 begins at caudate lobe. So, caudate lobe is the first segment. Why? It's actually, caudate lobe function-wise, it does not belong to the left side or the right side. It's a totally the lobe, the anatomical lobe of caudate lobe is actually a functional lobe. It also have its own drainage directly to the inferior vena cava. It does not drain through the hepatic veins, which is so important to know. I'll tell you in a moment. So segment 1 is caudate lobe. Segment 1 is caudate lobe. Then you move in circle, right? You have segment 2, which is in the left side of the liver. Segment 2 is left superior, lateral left superior. This area, which you can see in this diagram. Then you move to the segment 3, which is just in front. Of course, not that important to know, but I'm going to say it anyway. This is left inferior area. So, left lobe of liver contain segment 2 and 3. Okay? Segment 2 and 3. Again, you can see segment 2 here. left superior area, and segment 3, left inferior area, segment 2 and segment 3. Segment 4 is, as I told you, it's the quadrate lobe. As you can see, it functionally belongs to the left side of the liver, left hemiliver, and not to the right anatomical lobe of the liver. Although anatomically it's in the right side, but functionally it's belonging left hemiliver, quadrate lobe. Then actually, segment 5 is where the gallbladder sits. It's the fossa of gallbladder, segment 5. Then we move to segment 6, which is just lateral to that. We call it segment 6, right anterolateral segment. Right anterolateral segment, which is this also here, shown on this diagram. So that's segment 6. Segment 7 is behind that, which we call it posterolateral segment. Posterolateral segment. That's segment 7, sorry, that's segment 7. Okay, so in total we have 8 segments. The last one is this one, which is oriented posteromedial. Okay, is that important for exam? Not so much, except for 3 segments. So as if you watch, it's like clockwise. It moves in like a anti-clockwise. So that's caudate lobe starting at 1, then segment 2, then segment 3, then segment 4, then 5, right? Then 6, then 7, and then 8 actually is over here. Okay? Anyway, these segments, we call them Cohen-out segments, okay? Cohen-out segment. I think after a French surgeon. What are the segments that you have to know in the exam? Segment 1, which is know that it's caudate lobe, and segment 4, know it's quadrate lobe, and segment 5, know it's fossa of gallbladder. For what reasons? First, segment 5 is related to fossa of gallbladder. So if there's gallbladder carcinoma, direct invasion of the liver will occur first in segment 5. Okay? Segment 1, why we need to know it? Because it's caudate lobe and it's functionally independent. It does not drain through the hepatic veins. There's a syndrome which is called Budd-Chiari, which is simply just, it's more common in females. It's related with thrombophilias and things like that. It can also be idiopathic. But what happens is that all 3 hepatic veins become blocked by venous web or thrombosis. And that initially leads to acute congestion of the liver and hepatomegaly. But because of venous congestion, the liver becomes cirrhotic. All the liver except caudate lobe. Caudate lobe is the lobe or segment 1. It will be spared in what? In Budd-Chiari. Why? Because it just have its own little vein that does not drain to the hepatic vein, so it's spared. You get me? Now later on, because the liver, most of the liver is cirrhotic, this caudate lobe will undergo compensatory hypertrophy. And you know that is just next to IVC. So when it becomes very, very, very big, it can compress IVC and lead to lower limb edema and DVT. That can be a poem, by the way. I think it just came out naturally. So we can do something about that. We can put a retrohepatic stent that will just push it away. But just remember this very important clinical note. So important for us. Next, about the liver, we're gonna talk about the blood supply. Okay, so arterial blood supply. So what is happening? Of course, it's supplied by hepatic artery proper, which is a branch of common hepatic artery, which is a branch of celiac trunk. Now, this hepatic artery, it runs in the hepatoduodenal ligament, as I told you, anterior to the left, to the portal vein, and to the left side of the bile duct. So it will divide into right and left branch. The left branch will just go in its way to the porta hepatis. The right branch is usually retroductal, means it passes behind the common hepatic duct and then goes to the liver. From the right branch, right hepatic branch, cystic artery comes to originate and then passes and supplies the gallbladder. Is that right? So remember, cystic artery is branch of what? Right hepatic. Clinical importance here. Right hepatic may become enlarged right hepatic and it have tortuous course. It will actually enter this region, have a tortuous course, and then it goes very near to the neck of gallbladder and then comes back to the liver, up to the liver. Now the thing is that in this case, right hepatic artery is located in an anatomical region we call Calot triangle. Okay, Calot triangle. This region is so important for us. This region is bordered laterally and inferiorly by cystic ducts, superiorly by undersurface of liver, visceral surface, and medially by the common hepatic duct. This triangle basically contains fat, and it contains the cystic artery, this little one, and it contains a node called lymph node of Lund. It's a lymph node that drains the gallbladder called lymph node of Lund. Okay? So borders again, number 1, undersurface of liver, number 2, cystic duct, number 3, common hepatic duct. Common hepatic, because of course we know that when cystic duct joins common hepatic, it becomes common bile duct. So common bile duct is not a border. So its Calot triangle is used as an anatomical region to identify the cystic duct and cystic artery and ligate them during laparoscopic or open cholecystectomy. Okay? So, the thing is that the right hepatic artery may enter this region and move up. Is that right? Let's give it a different color. It may enter this region and then moves up. Instead of moving directly like this, it just comes here and then moves up. This situation means that intraoperatively you may mistake it for cystic artery. Since it's very near, you may mistake it for cystic artery and ligate it. Well, usually you'll be lucky and nothing will ever happen, but in people with already cirrhotic liver, bad liver, diseased liver, such element of ischemia to the liver by blocking the right hepatic or ligating it may precipitate acute hepatic failure, but in otherwise normal livers, it will usually not cause any issue. This anomaly is called, or this anatomical problem is called caterpillar. It goes by 2 names basically: caterpillar turn, like a caterpillar, or Moynihan's hump. Moynihan's, I think it's written like this. Moynihan's hump. It's one congenital anatomical variant that we need to know about. Okay? Alright. This region is full of questions in the exam. Actually, to be strict, there are 2 triangles here. Okay? This triangle called the original description of Calot triangle. The original description of Calot triangle is actually cystic artery, that's one border, common hepatic duct, and cystic duct. That's the original description of Calot's triangle. Again, it's cystic artery, cystic duct, common hepatic duct. Hepatocystic triangle is the undersurface of liver, common hepatic duct, cystic duct. But that's used interchangeably, you get me? But for strict purposes, if you want to be strict in literature, Calot's is actually one difference in the border is the undersurface of the liver. Instead of undersurface of the liver, it's cystic artery. And hepatocystic triangle is the undersurface of the liver, not cystic artery. So how can they ask you? But general, by the way, used interchangeably all the time. How can they ask you about this stuff? Well, I'll give you some example questions from the exam. Let's see that. First question. Which of the following is a content of Callot triangle which is ligated? So in operation, a content, not a border, which we ligate in operation, in cholecystectomy. Of course, if you can see here, a simply cystic artery. Answer is option A, right? Cystic artery. It's a content and we ligate it. Let's see another example. Which of the following is a border of Callot triangle which is ligated in cholecystectomy? A border, not a content, which we ligate. Again, let's review. Borders, cystic duct, common hepatic duct, do we ligate undersurface of liver? No. Do we ligate common hepatic duct? You will go to court and maybe be jailed for 5 years or something. If you ligate cystic duct, yeah, you want that. So cystic duct is a border that we ligate. So it's option C, cystic duct. Okay, let's see another example. Which of the following forms the medial border of Callot triangle? Of course, medial is common hepatic duct, so it's option A. Okay, let's see another example. During cholecystectomy, a surgeon ligates the cystic artery within the hepatocystic Callot triangle. So here in the question they treat it like the same. Which of the following structures usually form the lateral border of the hepatocystic triangle? So let's come back here. Lateral border is infralateral is cystic duct. That's lateral and below. So in the exam they can tell you inferior border or lateral border. So it's cystic duct, option D, right? Easy, easy, easy marks, free marks, basically. Okay? Okay, good. Right, so that's all about the anatomy of the liver. I hope that was satisfying and sufficient. I think it's more than sufficient. A great amount of details, just enough for purposes of many postgraduate exams though, usually. Okay, so that's it for today, guys, the lecture. Thank you so much for watching and best of luck.